So you can see X-ray is one of the commonest and easily available investigation everywhere, at least in Kerala. And it is one of the oldest investigation. And I would say it is underutilized because we are not spending time with the chest X-ray. X-ray makes images of the heart, lungs, airway, blood vessel, chest wall, bones, skin and soft tissue. So the entire chest structures are being included in a chest X-ray. Commonest indications are like chest pain, investigation of repeated or persistent chest infection, trauma to rule out any injury inside or bony trauma, localization of biopsy mets. I think when we were doing PG, that time CT scans were not available. So we used to take a PA view, lateral view to localize lesions for doing biopsy. Foreign body suspicion, again, X-rays, the one of the earliest investigation. Now, what are the projections while doing X-ray radiography? Standard view are there and additional views are there. This is a standard view which I have shown in the picture where the patient will be, chest will be close to the film and the source will be on the back. So the direction of X-ray will be from posterior to anterior part of the patient. Now we have a standard view like erect PA view, which is the best one to visualize the lung. This is, of course, done for fit and patient who can do it. Uh, it can diagnose most of the pathology in the lung and chest wall, and also to visualize the pleural effusion. While lateral view is a fantastic investigation, which is underutilized in the scenario where CT scans are available. But remember that in resource limited settings, lateral view give a good idea about where is the lesion and the characteristics of the lesion and to localize it. Now, additional views commonly used that one is supine AP or AP view, which we usually use in bedridden patient ICU settings or patient who cannot stand. Lateral decubitus view again, it is not utilized in nowadays after the ultrasound came into the picture, but it can be used to assess the effusion, especially when you get a blunting of the costophonic angle. Do a lateral decubitus view of that side. If the pleural effusion is 10 millimeter and above, you can definitely go for tapping it and see what it is. Expiratory view, remember that when you are suspecting small pneumothorax, if you take inspiratory film, it may not be evident. So always ask for the radiographer to do an expiratory view so that minimal pocket will be magnified. And penetrated PA view, where you are suspecting lower lobe lesions, where it is a retrocardiac, especially in the left side. So you can ask for penetrated view if you want to visualize left lower lobe lesions. And oblique view, of course, to assess the retrocardiac as well as the postophrenic angle area. Now we keep the central line of X-ray projection at the level of T6, that is sixth thoracic vertebrae, so that we will get a good image of the entire chest. Now, what's the difference between PA view and AP view? Why we are asking for PA view? Because in AP view, there will be magnification of the heart which occurs because we are keeping the film on the back side. Heart is anteriorly placed. The source of the X-ray is anteriorly. So whatever in the anterior most structures will get magnified. And of course, patient is unable to move the scapula away. So the scapula will be in the lung fields, which will mask your visualization of those part of the lung. And the clavicle will be above the apex. So a PA view is always preferred over the AP view. So you can see the difference here. The PA view, the scapula is away from the lung field. And the clavicle is at least 3 ribs below the posterior end of the 3 ribs. And you can see the diaphragm is well seen, cardiac size is normal. But if you take the same patient's AP view, you can see scapula is in, the lung area in this area is not very clear, and heart appears to be magnified. It is more than 50%, and lower zones very difficult to interpret in AP view. Now, how image is formed on X-ray? It is actually when you shine a beam of X-ray to a person and put a film on the other side, shadow is produced depending upon the the quality of structures. Uh, so if the bone, like any metal or bony tissue where the calcium are deposited, it will absorb the X-ray completely. When it absorbs completely, that part will appear in the X-rays white in color. Also, fluid also appears to be less white in the X-ray. Tissue is somewhat in between, so it appears gray. And if it is air, it will be completely black because the entire X-ray beam go through the film, so it casts black shadow. So you can see the different grades of shadows over here. Black means it is the air, but it is in the lung. And if it is white means it is a bone or fluid, like in the heart, it is always white. And gray is the lung tissue in between, or here, the soft tissue, which casts gray in color. Now, the quality of film is very important. Before interpreting any chest X-ray, we have to see whether the technique and also the quality of the film. It should be assessed in the following headings. Inclusion. Inclusion means whether the entire chest field is included or not. The projection also should be assessed. Rotation. Rotation will, if the film is rotated, patient is rotated to one side, your interpretation is will be very difficult. And whether patient has taken sufficient inspiration, that is also an important factor to get a good quality images in chest X-ray. Penetration, the kilovolt and the X-ray which is kept by the technician. If it's a thin individual, they have to reduce that. If it is an obese individual, they have to increase that. So the standard is useful. Standard kilowatt is useful for average weighted person. So the technician should adjust the thing. Usually these things are neglected in a busy schedule or an X-ray room which is overloaded. But still, we can ask for them to do an chest X-ray in the standard protocol. Now you can see inclusion means you have to verify that the first rib posterior is included, because if it is lung cancer, many times the apical lesion is missed. Tuberculosis, again, the apical lesions may be missed. Also, the outer part of the ribs are also included. Remember that the upper part of abdomen is also included, so that you will not miss anything in chest X-ray. Now coming to the rotation, the spinous process of the thoracic vertebrae should be in the midline. This we assess in the tracheal gas shadow in the upper thoracic spine, so that if it is in the midline and the distance between the spinous process to the either side medial end of the clavicle is equal, that means there is no rotation. If the X-ray is rotated to one side, the heart shape will be different. Suppose it is shifted to left side, the left heart will appear to be straightened and the right hilum become prominent. So these changes do happen when patient has rotation to the left side. If it is rotated to the right side, again the left hilum become prominent and the heart shape will be abnormal. Now you can see this is a it's a good X-ray taken without any rotation. These are the spinous process on the center, and these are this colored one is clavicle, medial end is of either clavicle is equal distance from the midline of the spinous process. So this is actually well centralized X-ray. Now you can see here what happens. This is the midline, and the medial end of the clavicle on the left side is over here, and right side it is very close to the midline, so it is rotated towards the left side. You can see the right heart border is not seen over here, and the right base is more radio loosened, and here you can see it is a little radio opaque. You are doubtful whether you have any minimal blunting or not. So these are the confusion which will be created by the rotated films. Now, whether the patient has taken sufficient inspiration or not. Remember that all chest X-ray PA view standard view should be taken in the full inspiratory phase. How to assess that? Ideally, the anterior end of the right sixth rib should intersect the right hemidiaphragm in the mid-clavicular line. So you can verify that. So you can see that this is the mid-clavicular line, and you can see the anterior end of the sixth rib crossing the diaphragm at the mid position of the diaphragm. If that is the case, this is a good inspiratory inspiratory film. Now, this is a classical expiratory film where the third rib is cutting the diaphragm. You can see the difference between these two. This belongs to the same patient, but you can see the left lower zone is opaque. You are doubtful whether any consolidation is there or not on either side, but it is more pronounced on the left side. So you are confused whether the patient is having pneumonia, especially when patient present with a fever and rigor and chills. You will be forced to admit the patient, seeing that there is consolidation. So that's the importance of assessing the X-ray, whether it has been taken in the proper full inspiratory phase. Now, penetration of X-ray means the degree of X-ray beam you adjust, the kilowatt you can adjust so that you will get adequate images of lung and the chest tissues. So you can see this is adequate. And if it is over penetrated, you adjust the kilowatt, or the patient is very thin, or you are increasing the kilowatt. What will happen? The thoracic vertebrae will be seen very clearly through the cardiac shadow. And lung field appears to be darker than the normal X-ray. I think these X-rays we are seeing many times in our day-to-day practice. The radiographers are, very busy with the X-ray, so they will not adjust the kilowatt according to the patient body, so that they may send the film with over penetrated. You can see this X-ray, you are practically unable to find anything in the lung. And if any subtle changes like find, small nodular lesions or miliary lesions, easily missed in over penetrated X-ray. Similarly, under penetrated X-ray is also problematic in the sense you will not be able to assess whether there is a real shadow or not. You will get hazy lung fields everywhere, and you can see the phosphochronic angle is not clear. So you may think that there is something in the lower zone, but when you repeat X-ray in the normal penetration, everything will disappear. So this is very important. On normal penetration and inspiration of the lateral view is very much underutilized. But when you take a lateral view, remember that when you trace from craniocaudally, the lung become more and more darker because more air-containing lungs are there in the lower zone. If this pattern is not seen, suppose here it is more whitish than the upper part, that means the lower lobe is having some lesions, like maybe pneumonia, maybe mass lesion, whatever it may be. So lateral view, the basic assessment is like this. You see the lateral view from craniocaudally. It should be more and more darker when you approach down. Now, one important structure in the mediastinum to start with is trachea. So you should know the basic anatomy of the trachea, and it's start from C7 till the T4 or T5, where it divides into right and left. Main bronchus length is 10 to 15 centimeter. Internal diameter is 10 to 18 millimeter. This is important because tracheobronchomegaly, Meunier-Kuhn syndrome, it should be more than 22 millimeter. And the cartilage, of course, 18 to 20. Remember that these cartilages in a healthy adult is not calcified. If you find a calcified cartilaginous ring in middle age or a younger individual, always think of some abnormality like relapsing polychondritis or amyloidosis or tracheobronchopathia, osteochondroblastica, something like that. So cartilage calcification is also important, and the trachea divide into at the cardiac level into the right and left the main bronchus. And remember that it passed to the right of the aorta. Now you can see this is a shaded one is the trachea. You can see the right bronchus is continuous with the trachea, so that aspiration possibility is more on the right side, especially when patient is standing up. And the left is little more obliquely placed, and it is divided again to the upper lobe and lower lobe. So it is always better to see the gas shadow of the trachea from top to bottom. You may be surprised to see some lesion in the lower end of trachea, maybe some malignant lesion or maybe some foreign body. Unless you are looking for it, you may easily miss the tracheal lesions. On lateral view also, you can see the trachea. And you can see the right and left main bronchi. Now, hilum. Hilum is the wedge-shaped lesion, wedge-shaped area on the central portion of each lung. Now, it contains bronchi and the pulmonary vessels. Remember that the hilar nodes, when it is enlarged, it may confuse you whether it is an enlarged pulmonary artery or not. So it is always better to assess the hilum and see what it is. How to assess the hilum? You have to trace the upper lobe vessels, you have to trace the lower lobe vessels. Meeting point is taken as hilum. And on the left side, you can see the left hilum is higher than the right hilum. Now, you can see the upper part of the lung fields, the vessels are not prominent. You can see the mostly the vessels are seen on the lower part. These are the pulmonary arteries. And if the upper lobe vessels are prominent, that means the pulmonary veins are prominent on the upper portion. That indicates pulmonary venous hypertension. Especially this happens with mitral stenosis. So always look for the upper lobe vessels. If they are more prominent than the lower lobe vessels or equally prominent, think of pulmonary venous hypertension. Now the fissures and lobes of lung. Lung have two major fissure and minor fissure, which is on the right side. Major fissure is oblique fissure, minor fissure is horizontal fissure. Lobes are right side, we have three lobes divided by the oblique fissure and the minor fissure. Left side, we have only one fissure and two lobes. Now, this is the basic anatomy of right and left. You can see the upper lobe and which is separated from the middle lobe by the horizontal fissure, and both these lobes are separated by the oblique fissure. On the left side, we have only one fissure, and upper lobe and lower lobe is being separated. Now, bronchopulmonary segment, these are very important because we have some of the diseases are specific for each bronchopulmonary segment. So, each bronchopulmonary segment is actually anatomically, functionally, surgically separate units of the lung. Surgically, when you want to remove lesion on one segment, that can be removed alone. You need not do a lobectomy. It has its own bronchus, its own circulatory, its own lymph vessel, everything is so you can remove it if it is disease. So it is always better to know the segmental anatomy by taking chest X-ray PA view and lateral view. Now this is the basic the anatomy of the segments which is appearing on the chest X-ray PA view. So you can see the apical part of the X-ray is apical segment of the upper lobe, and the most of the anterior area is occupied on the right side by the anterior segment, left side by the anterior segment of the left upper lobe, and a limited portion of the outer portion of the chest X-ray is occupied by the posterior segment of the upper lobe, and this is the horizontal fissure. The close to the heart shadow will be the medial segment of the middle lobe, and outer to that you have a lateral segment of the middle lobe, and you can see very small portion is seen in the anteriorly the lower lobe, because most of the lower lobe is behind the anterior segment of the upper lobe and the middle lobe. On the left side, we have a lingula instead of middle lobe, which is very close to the heart. You can see this is the cardiac area, which is very close to the heart. So any lesion which is silhouetting the left heart border will be in the lingula, and on the right side it will be in the middle lobe. Now, if you want to mark in a chest X-ray, you can see the upper lobe occupy all this area, and middle lobe close to the heart, and this portion will be the costophrenic angle will be the lower lobe. And in the left side, you can see the upper lobe occupy anteriorly most of the area, and the lower lobe in the costophrenic angle area. So this is upper lobe, and it's always asked for lateral view so that you can identify the bronchopulmonary segment. How to identify the bronchopulmonary segment? This entire shaded area you can divide into three equal parts. So the posterior part will be the posterior segment, and this part will be the apical segment of the upper lobe, and the anterior one third will be the anterior segment of the right upper lobe. This is very important to know the which segment is being affected. Now, here you have right middle lobe. In the lateral view, you can definitely assess the medial portion will be the medial segment, and the outer portion will be the lateral segment of the right middle lobe. Now, lower lobe occupy again, there will be a lot of overlapping. Never think that upper lobe occupy on the upper half and lower lobe occupy on the lower half, because there will be a lot of overlapping. You can see this area is for apical segment of the lower lobe, and we have three basal segment of the right lower lobe over here. In the lateral view, it's very clear. See, this area is for dedicated for lower lobe. So this is for apical segment of the right lower lobe and the mediobasal segment, laterobasal segment, posterobasal segment, anterobasal, all come in the lower portion of this lower lobe. Now, coming to the left side, we have the left upper lobe occupying almost everywhere in the anterior part of the chest. And if you take a lateral view, it will be very easy to separate from the lower lobe. This area is for only for left upper lobe, and this area for lower lobe. And the upper portion will be the apical segment. We have only three basal segment in the left side, which is anterior, lateral, and posterior basal segment. Now, I think these are the lower lobe area which you can mark in the PV. Remember that there is again overlapping of the lower lobe and upper lobe in the PA view. So any lesion over here may be in the lingula, maybe in the lower lobe. So this concept should be there in your mind. So it may be in the anterior or posterior, but take a lateral view to confirm whether it is in the upper lobe or lower lobe. Now, usually we describe the lung lesion in terms of lung zones. How to mark lung zones? Very easy. You have to trace the rib. This is the first rib, second rib, make the anterior end of the second rib, make a point over here, and make a horizontal line. Whatever above will be taken as upper zone. Similarly, you take the fourth rib. This is the first rib, second rib, third rib, fourth rib, anterior end, and you make a point over here. Between these two points will be the mid zone, and below will be lower zone. Why we are making this area division? Because if I am seeing an X-ray, I say it is in the upper zone, so that if another doctor is seeing, okay, he expects the lesion in the upper zone. Suppose it is over here, I will say that it is in the upper zone as well as extending to the middle zone, so that I can communicate to the other doctor over phone, so that he will understand where the lesion is. That's the beauty of describing this thing in the X-ray. So we are dividing them into the upper, mid, and lower zone. Never, some people are saying that upper zone for upper lobe, mid zone for middle lobe, and lower zone for. It's not like that. It is just we are described the lesion according to the two arbitrary line. Now, the cardiac chambers very important to assess the cardiac chambers, because sometimes superior vena cava may be enlarged over here, causing a mediastinal widening. Right atrium may be enlarged, or left atrium may be enlarged, which will cause the shadow in shadow or double atrial shadow. When right ventricle is enlarged, it will lift up the left ventricle, causing a boot-shaped heart. If left ventricle is enlarged, it will cause a cardiomegaly, where it is touching the diaphragm. And if pulmonary artery is enlarged, it will cause the pulmonary trunk prominent in the hilar area. So all these structures should be there in your mind when you are evaluating the mediastinal structure, especially the cardiac chambers and the great vessels associated with. Now, cardiothoracic ratio is an important parameter to assess the cardiomegaly. How to assess? You make midline, then you assess the maximum deviation towards the right side in the cardiac area, also towards the left side maximum, and you add both these from the midline. That will be the cardiac diameter, and you assess the thoracic diameter maximum dimension over here. You make the ratio. In males, usually it is less than 50%, and female, it may go up to 55, but it should be less than 55. Neonates, of course, it will be more. It may reach up to 65%. If cardiomegaly is there, definitely you have to assess which chambers are enlarged or not. Now we can see the diaphragm over here, right and left diaphragm. Usually the right diaphragm is little higher than the left diaphragm. And to identify stomach bubble on the left diaphragm and the lateral view, the diaphragm which is silhouetting the heart will be the left diaphragm, and the one which is not silhouetting go and their anterior chest wall will be the right diaphragm. This is how you identify the right and left hemidiaphragm in the lateral view. Remember that the right lateral view will have right hemidiaphragm higher than the left, and the left lateral view will have left hemidiaphragm higher than the right hemidiaphragm in normal conditions. Now, bony shadow is often neglected in chest X-ray assessment for lungs, but you will get important clue like any bony erosion, notching of the ribs, fractures, pathological fractures. So all these things should be assessed. What are the bones, clavicle, ribs, scapula, spine, all those things should be assessed. Sometimes we make it osteoporosis, osteoarthritis, bamboo spine, so many findings you might get, and also sometimes the lytic lesions of the metastasis as well. So bones assessment is very important. Check individual bone and look for any abnormality, record it, and correlate with the lung findings. Now, soft tissue often neglected. You can see breast shadow is absent over here. Sometimes these patients may present with effusion, maybe a mastectomy before. Sometimes the entire pectoral muscles may be absent, like in Poland syndrome. Sometimes you may get a lesion over here, like neurofibromatosis. You might get a calcified lesion for calcified lymph nodes over here. So look for entire soft tissue assess. It is said that you can assess the nutrition of the patient by seeing the chest to soft tissue thickness. If it is very thin, skin and bone together, that means patient is undernourished. And if it is, this is okay. So even nourishment can be assessed. So soft tissue assessment is very important in chest X-ray interpretation. Now, how to read chest X-ray? Very simple. 10 points should be assessed. The first point is the quality of the X-ray. Check the patient detail, date of the X-ray, penetration, quality, rotation. Is this X-ray adequate for us to say that confidently that this X-ray is normal or abnormal? So these points are very important. Sometimes you might get previous X-ray. I have seen patient bringing old X-ray, and we are thinking that still the pneumonia is there, but unless you check the date, you will be confused. So date checking, name checking. Patient may bring another patient's X-ray, or the X-ray technician might send another X-ray. So these issues are not very rare. So be vigilant. Confirm whether your X-ray belongs to that patient. It is the date is confirmed. Also the technical issues. Start with the skin and soft tissue. I usually start with the skin and soft tissue. I will not. The usual dictum is when we are seeing chest X-ray, everyone will look or stare to the lung, and if anything is seen, they will report. If not, nothing is there, we'll report it as normal. That practice should be stopped. Always systematically assess the chest X-ray. Start with the technical details, then go for the skin and soft tissue one by one. Try to find any abnormality if it is there. Also check bone one by one. Look for any abnormality. Go to the tracheal gas shadow. Any abnormality, any intratracheal lesions, tracheomegaly, tracheal ring calcification, if it is there, should be documented. Mediastinum from top to bottom, right paratracheal area, usually there is no widening. If anything widened, then you have to think of process of mediastinal widening. Then go to the aorta arch, aortic arch, the cardiac chambers, right atrium, also the left heart border, starting from the pulmonary trunk area, left atrium, atrial appendages, and left ventricle. Then assess the cardiothoracic ratio as well. So now the next point will be the cardiophrenic cosophrenic angle diaphragm. Diaphragm, you have to see whether it is regular or not. Sometimes you might get a diaphragmatic hernia. You might get a partial eventuation of diaphragm, full eventuation of diaphragm, diaphragmatic palsy. Sometimes you might subpulmonic effusion. You will get a lateral peaking of the diaphragm. So all those things should be assessed. Sometimes you might get air under the diaphragm, especially when there is intestinal perforation or post laparoscopy, laparotomy, you might get air under the diaphragm. So these things are very important. Sometimes you might get below the diaphragm air fluid level, especially the necrotizing liver abscess as well. Next important structure is hilum. Always look for the hilum, any prominence in the hilum. Assess the pulmonary artery size. Pulmonary artery size may be enlarged in pulmonary hypertension. And sometimes you will get a huge pulmonary arteries in atrial septal defect, cardiac valvular disease, pulmonary hypertension. So pulmonary hypertension, you will get a clue from the assessing the hilar structure. Lung fields, I would suggest to see lastly, lung field you should make as a last point, because you will get a lot of clue from the other area. If you are looking into the lung field, you will stuck with lung field. So again, lung field you can divide into upper, mid, and lower zone. Compare the right upper zone with the left upper zone, like mid zone with the left, like that. And you are finding anything, describe the lesion. You will be getting the standard description of lung lesions are nodule, infiltrations, or consolidation. So like that, you have to, or mass lesion. So accordingly, you have to comment what is there in the lung fields. Lastly, It is for you to look for hidden area. Always the hidden area lesions are missed. If you are very good in reading X-ray, interpret the hidden area after assessing all the area. What are the hidden area? Look for the apex. Apex, you may get any apical fluid thickening, erosion of the rib, or maybe a pancreas tumor. Go for the mediastinum, right paratracheal stripe may be enlarged. You might get a retrocardiac area, especially the left lower lobe lesion or hiatus hernia. All those things can happen in the retrocardiac area. And below the diaphragm, you look for any emphysemas or any gas under the diaphragm. Also, mediastinal emphysema, you might get in the pericardial area. So all those points should be assessed. So the hidden area, you should spend at least 1 minute to check for the hidden area. You will be surprised to diagnose many diseases in the hidden area. Now, these are the points which I have summarized above. The spinous process to assess the rotation of the X-ray. So you make a midline over here on either side medial end of the clavicle. This is a perfectly film which is not rotated at all. This is a tracheal shadow. You can see the right main bronchus, left main bronchus. Now the mediastinum, right paratracheal area, there is nothing. So there is no mediastinum widening over here. And you can see this is the subclavian artery, this is the aortic knuckle, and below you will get the pulmonary trunk. This is an area for pulmonary trunk. If it is enlarged, it is pulmonary trunk prominence in the pulmonary hypertension. And this is the concave area. Usually, this is a concave area for the left atrial appendages and left atrium. If it is filled up, that indicates a straightening of the left heart valve. Usually happens with the mitral stenosis. And you can see the left ventricular border over here. The apex is touching the diaphragm. If it is a left ventricular hypertrophy, this apex will be elevated, causing the cardiomegaly with a boot-shaped heart. And you can see the cardiophrenic angle, nothing is there. It is normal, and the cosophrenic angle is acute. Here also, cosophrenic angle is normal. Diaphragm is, the shape is normal. The maximum peak is in the middle, and you can see the gastric fundic bubble. Now you go for the hilum. You can see the upper lobe vessels are not very prominent. If it is prominent, always think of pulmonary venous hypertension. Lower lobe vessels are more prominent, and the artery is not enlarged. And you can see the hilum is normal. Finally, the lung zones, 3 zones you have to see. After that, go for hidden area. What are the hidden area apex? Anything over here, and go for the retrocardiac area and retrodiaphragmatic area below the diaphragm, any air or anything like that. So this is the order you have to assess. Technical things are the first one: skin and soft tissue, bone, mediastinum, heart, diaphragm, CP angles, hilum, lung area, hidden area. And if you have a lateral view, again, you can look for any abnormality in the lateral view as well. Now I will have some of the X-ray. I think, am I audible? Yeah.
Yes, sir.
Now I will show some X-rays. Some of you can volunteer and diagnose it. It's not very complicated X-ray, simple X-rays which you are seeing in your day-to-day practice. Can anyone tell what it is?
Pleural effusion, right side
Pleural
of the
effusion. But is it a classical pleural effusion? Usually in the pleural effusion, you get a Ellis curve. Ellis curve means a concave border over here with the peaking on the lateral aspect like this, but this is not like that. So this is actually subpulmonic effusion where you get a lateral peaking. This is something like a diaphragm which is showing the lateral peaking. So this is a case of subpulmonic effusion. Your answer is correct, pleural effusion, but this is here the fluid is between the lung base and the diaphragm. That's why you get an abnormal shadow like this. We'll go to the next image. Can anyone volunteer this?
air in the
Left
Yeah. Yeah. What is happening is here, there is a loosened area over here, right? You agree with me, right? This is a loosened area, and you can see a border over here. So when a hyper loosened area with a border of lung, that is a definition of pneumothorax. But you can see a fluid level over here, horizontal level. So this is not a simple pneumothorax, rather it is a hydropneumothorax. So yeah, hydropneumothorax. So very good. Now, can anyone say this X-ray?
Interlobar
Bulging fissure
effusion.
sign.
Sorry, I didn't hear.
Bulging fissure sign.
Yeah, very good, excellent. Any other name you know of this?
Interlobar effusion.
Phantom tumor.
Yeah, phantom tumor. I think it's a very funny name, phantom tumor, because you can see here the both the CP angles blunt. There is a fusion on the right side. Usually, this happens in the scenario of cardiac failure. When you give Lasix or diuretics, the this tumor will disappear. That's why it is called. It looks like tumor, but it is actually fluid between the horizontal fissure. Now, can anyone say? Yeah, try. These are the simple X-ray you will be seeing in your practice, one or two X-rays like this every month. So basically, you assess what is happening over here. Right upper zone, there is a opaque area, right? And here also you have opaque area. So this is actually a pleural effusion on the down, and there is some mass lesion with the encysted fluid over here. It's not very clear unless you take a lateral view, but effusion is confirmed over here. Here the paramediastinal mass, some encystment. We can see the pleural line all the way here. This is the pleural line, not the rib border. Pleural line over here. So there should be some encysted fluid on the top. Can anyone say about this X-ray? This is a very common X-ray. This patient had a history of pulmonary tuberculosis during childhood and took 1 year ATT long ago. Yes, right?
Traumatic herniation.
Yeah, this is actually, you assess step by step. This is the trachea. You can see the trachea is occupying the left hemithorax, and you can see the pleural thickening over here. The ribs are covered over here, and practically there is no lung tissue on the left side. All these are occupied by the right lung, right lung herniation. That's why the cardiac shadow is not there seen. Cardiac shadow is shifted towards the left side. Left hemithorax has shrunken, and the left lung has been replaced by fibrothorax. So this is a case of you call it as destroyed left lung with hyperinflated right lung with over herniation. Other differential diagnosis for this is lung hypoplasia, especially left lung is hypoplasia there, or left lung agenesis. But this is not left lung agenesis because you are able to see the left main bronchus and its division. So in agenesis, you will not see the left bronchus. Is it clear? Okay. Again, you have to see step by step. Here the trachea has gone to right side. And on the apex, you can see there is opaque area over here compared to the left side. So there is apical pleural thickening, and the ribs are crowded. And hilum, where is the hilum? You trace the lower lobe vessels. It is going all the way over here. So the hilum has gone up. Hilar shift is a sign of collapse. So here, signs of fibrosis and signs of collapse. So this is a cicatricial collapse or fibrotic collapse of the right upper lobe, which shift the trachea towards the same side. But remember that left side is also not normal. You can see fibrotic, patchy fibrotic area here and there. So this must be a case of post-tubercular sequelae with the right upper lobe fibrotic collapse. The important signs of collapse is hilar displacement, fissural displacement, crowding of the vessels, mediastinal shift. So here, 2, 3 signs are there. So you can safely say it is collapse. I think this X-ray you can diagnose. Very simple. Can anyone please?
Miliary.
Yeah, miliary. Yeah, very good. So this is miliary tuberculosis, mostly tuberculosis, miliary shadows. Miliary shadows, it's having its own differential diagnosis, but in our in our state, in our country, the most common differential diagnosis is biliary tuberculosis. This one, can anyone say? So this is actually a portable AP view, not a very good quality X-ray. You can see the lesion attracting in the upper zone area. You can see the air shadow in the bronchus, which is called air bronchogram, which is diagnostic of consolidation. When you get air bronchogram, it is almost a diagnostic of consolidation. You can see the horizontal fissure has gone up. So this is a consolidation with the partial collapse of the right upper lobe. I think this is very simple. Please.
Right pneumothorax.
Very good. The definition of pneumothorax is hyperlucent area without bronchovascular marking, collapsed lung border medially. When you get these 2-3 items, you can safely say it is pneumothorax. What about this one? So you assess the mediastinum. What is happening? This trachea has gone over here. Mediastinum has gone to the left side. You are not seeing the right heart border. And you can see some peculiar thing over here. What is this? There is some horizontal line, right? There is a rounded thing with a horizontal line. Rounded thing, horizontal line. Another rounded thing, horizontal line. These are multiple bronchiectatic cysts with the infection. So infected bronchiectatic cyst over here and trachea gone to the left side. So there is a parietal, the pleural thickening on the apex, crowding of the ribs. So there is a cicatricial collapse on the left upper lobe. You can see fibrosis over here. There is a pleural thickening on the both the costophrenic angles. So many findings in this X-ray. So this must be a post-TB sequelae with infected bronchiectasis of the left lower lobe and upper lobe. This one. So you can see patchy haziness over here, which is ill-defined. You can see the air in the bronchus as a shadow over here. And you can see the left heart border very clearly over the lesion. That means the lesion is not in the lingula. Suppose you are able to make out the cardiac border very clearly from a lesion in the mid-zone, lower zone of the left side. That means the lesion is in the lower lobe. Another clue for this lower lobe lesion is diaphragm is not seen very clearly. Any lesion silhouetting the left diaphragm will be in the lower lobe. So this is a lower lobe consolidation. That should be the diagnosis. In addition to that, you can see the cervical rib. You can see a small rib which is going to the cervical transverse process. How to identify cervical rib? You have to see the transverse process of the thoracic vertebrae, which is upward. You can see these are the upward transverse process of the thoracic vertebrae. But the cervical vertebrae will be transverse possibly downward. So this rib is going to the cervical thoracic cervical vertebrae. This one, these are very common X-ray in your practice. You can see a patch over the right side and also the left side. So this is the bilateral pneumonia, the pneumonia occupying in the right upper lobe anterior segment, and here left lower lobe. So bilateral pneumonia. Can anyone diagnose this? This is very one of the simple X-ray. Yes, come on.
Encysted effusion.
Left side pleural effusion. Do you think this is a classical pleural effusion? Encysted. Very good. Yeah, very good. Because this is convex rather than concave. So when you get a convex border over here, it is not a classical effusion. It is encysted. So D-shaped effusion. Usually we call it as D-shaped in chest X-ray. If it was classical effusion, it should be concave border. Now, what do you think this one? What are they? They are the air bronchogram. So this is a dense pneumonia of the entire right lung with a partial collapse. The trachea has gone to the right side. Some of the pneumonia, when the mucus plugs are really thick and it may allow the lung, peripheral lung to collapse. So you get a volume loss. So these patients, ideally, you have to do a intense chest physio, postal drainage, or bronchoscopic drainage of the intraluminal, intrabronchial mucus plugs. This one, this abnormality over here.
Chaos
Anything
under
here?
diaphragm.
Yeah, actually, it is not gas. It is actually a colonic loop under the diaphragm. This is called Chilaiditi syndrome, where the colonic loop placed between the diaphragm and the liver. This is a tricky situation. If this patient develop a pleural effusion or empyema, you will put needle into the colon. If you put an intercostal drainage, you will puncture the colon. Finally, this will create colonic fistula, colonic fistula, where the drainage will not be stopped. So the patient will have feculent discharge through the ICD. So this is a tricky situation. So if your patient is having Chilaiditi syndrome, when they present with something else like pleural effusion or empyema, you have to do under image guidance. This is one of our patient who is a smoker for many years with a smoking index more than 900, came with a loss of weight, hemoptysis, clubbing. What could be the thing?
With the cavitation.
Yeah, this is a mass lesion which is undergoing cavitation. When you get a thick walled irregular cavity, always think of squamous cell carcinoma or small cell carcinoma. Any other finding in this X-ray apart from this?
Rib
You can see the
erosion.
rib erosion doubtful, but you can see the paratracheal area. What is this one? Normally we get empty over here, but here there is a bulging out. This is the tracheobronchial lymph nodes, right lower paratracheal lymph nodes, and you can see the upper paratracheal lymph nodes. So this is a cavitated mass with mediastinal lymphadenopathy, most probably squamous cell or small cell lung cancer. Try this one. So it's, yeah, come on.
Veneration
You
of
are not on. Very good. Very good. Excellent. So the diaphragm has gone up. This may be ventilation or maybe diaphragmatic palsy. We don't know. Diaphragm has gone up. That's what the image says. If you want to document whether it's ventilation or the phrenic nerve palsy, go ahead with ultrasound to assess the movement of the diaphragm, thickness of the diaphragm. If diaphragm is thick and not moving, it is phrenic palsy. If diaphragm is thin, flap-like, but minimal movement is there, it is event rash. This one very simple.
Thymoma.
Yeah, we can say that there is a mediastinal mass in the right paratracheal area. Differential diagnosis most common is retrosternal thyroid, thymoma, but usually thyroid will have a continuity with the neck mass. There is not there, so thymoma should be the first one, or maybe a large lymph node, maybe teratoma. So all these comes as differential diagnosis. Sometimes mediastinal cyst can also present like this. This is classical X-ray.
Yes. Dextrocardia.
Yeah, very
With
good.
that
Anything else?
syndrome.
Titus inversus.
Yeah, this is
Bronchiectasis.
right. Bronchiectasis is
Cartagena
not there.
syndrome.
Cartaginous syndrome.
Cartagena syndrome. Any other syndrome you know? Bronchiectasis with ciliary dyskinesia. Young syndrome also, right? But this is situs inversus. There is no bronchiectasis, so we cannot call it as cartaginous. Why it is situs inversus? You are seeing the gastric bubble in the right diaphragm and liver probably on the left side. So there is a the structures on the right side is on the left side and left side is on the right side. So when viscera is also involved, we call it as situs inversus. If the fundic bubble is on the left side, then we call it as pure dextrocardia. So this is situs inversus. Yes, this X-ray.
Right pneumothorax.
Yeah, usually you think of pneumothorax, but when you look very carefully, yeah, you can see a hairline shadow over here, right? And another hairline
Bulla.
shadow over here. Yeah, very good. It is a
Emphysema
large bulla, a
bulla.
large bulla. Yeah, giant bulla. We call it as giant bulla because it's a very large one. And also it is a tension bulla. Why it is tension? It causes the diaphragm to goes down. It causes the mediastinum. It press the atria towards the left side. So this is a tension bulla. So this should be either operated or you can put a small catheter to relieve the tension, which is a risky procedure, but always a surgery would be a better choice if patient is symptomatic. Yes. Any peculiarity in the shape of the heart?
Pericardial
Cardiomyopathy.
Pericardial.
Yeah, pericardial effusion. Very good. Can you say the sign?
Water bottle sign.
Not water, leather bottle sign, right?
Ah.
Leather bottle. Yeah, leather bottle sign. Very good. Very good. When you find the cardiac shadow like this, always go refer the patient to cardiologist or do an echo test. Patient will be having moderate to massive pericardial effusion. Yes. Want to take chance? Come on.
Again, dextrocardia.
Dextrocardia. Actually, how to assess cardiac, I will tell you. You make a midline in the spine and you measure towards the right side, measure towards the left side. Normal cardiac shadow, we call it as levocardia, where 2/3 will be on the left side, 1/3 will be on the right side. There is an anatomical variation, mesocardia, where 50% will be on the left side, 50% will be on the right side. In dextrocardia, the reverse of the levocardia. That means 2/3 will be on the right side, 1/3 should be on the left side. But do you think there is 2/3 on the right side? Not there, right?
Not.
Not there. So we can't theoretically call it as dextrocardia. But here the problem, you compare the upper zone with upper zone. This is the hidden area. What is happening? Hidden area opaque on the right side. So that means there is some pleural based abnormality over here. Maybe pleural thickening, maybe lesion over here, we don't know. But there is a abnormality over here. And cardiac shadow is little abnormal. And you can see the cardiophrenic angle is obliterated. Usually we find cardiophrenic angle like this, right? But this is obliterated. In such scenario, always think of any lesion in the lower lobe in the cardiophrenic angle or any partial collapse of the right lower lobe with some lesion over the apical lesion. So these cases, ideally, you have to subject the patient for CT scan. Then you will be clear about what is there in the apex of the lung and regarding the lower lobe, any collapse is there or not. This one, little
Air under
straightforward
diaphragm.
exercise. Very
Air
good,
under
very good,
diaphragm.
excellent. Air under, yeah. What are the differential diagnosis for air under diaphragm?
Perforation. Ventricles or perforation.
Perforation.
Yeah, yeah. If it is an acute, a patient comes to an emergency room with upper abdominal pain, collapse, BP4, always think of peptic ulcer or any GI perforation. In a post-op ward, it is a common finding in post-laparoscopy. So don't be panicked when you are seeing a patient in a post-op ward. This one. Actually, this patient came up following a road traffic accident. So you have to see the individual bone one by one. When you trace the bone over here, what is happening? These ribs are not continuous, right? Yeah, there is some break in the rib. So that's a beauty. You have to see the all bony structures one by one. Then only you will be able to diagnose fractures. Sometimes the patient might present with you pathological fracture of one rib. They will have intractable chest pain, inspiratory pain, pleuritic pain. But if you are, unless you are looking for each rib, you will miss the diagnosis. So always keep eye on the ribs whenever patient present with pleuritic kind of pain. This one,
Mediastinal widening.
very good. It is a bilateral hilar lymphadenopathy. You can see here also lymph nodes are enlarged. Bilateral symmetrical hilar lymphadenopathy. What are the differential diagnosis? Commonest diagnosis?
Sarcoidosis.
Excellent,
Lymphoma.
excellent. Sarcoidosis is the first one, followed by tuberculosis, lymphoma, berylliosis. These are the classical differential diagnosis of mediastinal hilar symmetrical lymphadenopathy. Most common being sarcoidosis. This patient came up with viral flu 1 or 2 days, followed by rapidly worsening respiratory distress, and patient is
ARDS.
ARDS.
ARDS. Excellent. You can see there is a endotracheal tube inside, and at least 70% of the both lungs are white. Then that is the one criteria. ARDS. First criteria is acute onset, less than 7 days. X-ray involvement more than 75%. PF ratio less than 300, and you have to rule out cardiac failure, pleural effusion, mass lesion by an echo test. And patient should be on non-invasive ventilator, at least 5 centimeter pressure support. If all 4 criteria are satisfied, you call it as ARDS. But time being, this is an X-ray class. X-ray wise, it is ARDS. This is also a mild version of the previous X-ray. But do you think it is ARDS? Any other differential diagnosis?
Feel
Pulmonary edema.
Excellent. This is pulmonary edema. So pulmonary edema will confuse you with ARDS. But the beauty is here, the lesions are all around the hila. You can see the costophonic angle and the periphery is relatively spared. So when you get bat wing, that means the perihilar distribution of the nodules and infiltration, always think of pulmonary edema rather than ARDS. This is a 9-year-old child presented with acute respiratory distress while playing.
Foreign body.
Excellent. What type of foreign body it is?
Nail.
Yeah, very good. So this is in the right main bronchus. You can see screw because right main bronchus is in alignment with the trachea, so it's straight away going to the right main bronchus, causing the respiratory distress. Yes. This patient actually came to me 2 weeks ago. He's a post-COPG patient, which was done 2-3 years ago. Now his problem is facial edema while he's getting up from bed and breathing difficulty and stridor.
mediastinal widening.
Yeah, there is a mediastinal widening. Yes, this is the area for the lower paratracheal lymph node, just above the right main bronchus, and between the trachea and the right main bronchus. This angle is for lower paratracheal node. You can see a bulge over here, and in the CT scan there is a huge lymph node in this area, compressing the superior vena cava, compressing the trachea. That compression is not seen in the X-ray, but in the CT scan it was there, and we did EBUS guided biopsy from the node. It was actually non-small cell lung cancer adenocarcinoma. We did emergency radiotherapy, and patient slightly better today. So this is always look for this hidden area. That's why I told you earlier, hidden area should be assessed, especially when patient is symptomatic. Any positive findings? Do you think this area is normal? There is some lesion on the right para-aortic area, which was actually a calcified lymph node in the CT scan. Any abnormality? We have only few more X-rays. Yes. Yeah, but this is the area of showing some lesion, some irregular shaped nodule over the left upper zone. I will show you the corresponding CT. You can see this is the mass lesion, which is the shape is little abnormal. It's not a rounded thing. Elongated irregular lesion occupying the para-aortic area. This was a case of lung cancer. This patient is actually a TB patient, old TB, which happened 20 years ago, now presented with the hemoptysis, weight loss for past 6 months, heavy smoker. And his previous X-ray was only for little bit fibrosis. And this shadow appears to be new lesion. What do you think?
Carcinoma.
Yeah, cancer occurring in the TB scar. Usually it will be adenocarcinoma. So you can see this is a corresponding CT of that patient. These lesions are quite new lesion. There was some fibrosis in the previous X-ray, but I have not shown that. Whenever there is a TB scar which is increasing the shadow, like in a nodule developing in a TB scar, always think of adenocarcinoma. Yes. We have only few more X-rays. You have to see the X-ray, upper zone, mid zone, lower zone, lower zone. Anything which is not usual or something. His left cardiac shadow is normal. Yeah, there is some silhouetting lesion with air shadow over here. When you take CT, it will this is a cavity, large irregular thick wall cavity with bronchus is cut off, upper lobe bronchus is cut off over here. So this must be lung cancer. This patient came to me again post CABG, presented with loss of weight, loss of appetite, minimal hemoptysis, not a smoker. When you get hemoptysis, this is one of the alarming symptom of either tuberculosis, pulmonary embolism, or malignancy. But a chronic symptoms, usually you have to think of TB versus malignancy. Any clue in this X-ray? Yes. Probably it is not clear. You see the diaphragm. Compare the left diaphragm with the right diaphragm. What is happening over here? Do you think it is normal? Normally we get a diaphragm, a single shadow like this, right? You have two more shadows over here. When you get two shadow, it may be partial ventilation. Three, you have to think of, especially a symptomatic patient, you can go ahead with the CT scan. Now what is happening? The third hump is actually a mass lesion. So the right sided you have mass lesion. So this is the mass lesion which is occupying over here. So whenever patient is symptomatic, always search for hidden area. This is the hidden area, which is likely to be missed if you are not evaluating properly. Now this one, again search for hidden area. This X-ray I kept for you to look for hidden area, the importance of hidden area. The area here is retrocardiac area. What is happening? This is not normal. Something opacity over here. Normally the aorta goes like this parallel to the vertebrae. This could be either aneurysm of aorta or something else in the lower lobe. So what will you do? You have to go ahead with the CT scan. So you can see a large mass lesion occupying close to the aorta. That's why it is in the retrocardiac area. Again, I will show you the previous X-ray. So when you get a shadow like this, think of aortic aneurysm or mass lesion. In this patient is symptomatic. So think of malignancy. And you can see here, there is a metastasis to the opposite lung. These are the nodular lesion in the opposite lung. So this is a stage 4 lung cancer, which is inoperable. Yes, this one. Again, you have a irregular lesion in the right upper zone, which is spiculated, looking like malignant lesion. Obviously, when you look, this X-ray appears to be normal, but it is not abnormal. Not normal. This is abnormal. Why abnormal? You select the upper zone with upper zone. You can see something over here, which is not there over here. So when you ask for a CT scan, you can find nodule in the lung. So this is a case of lung cancer. But when you casually see this X-ray, you may think it is normal. But when you systematically examine this X-ray, you can find out a nodule in the right upper zone. Yes, this patient, I think, referred from one of other local hospital with acute severe asthma. He has bilateral V's. We have given nebulizations, not improving. We have given all management of severe asthma. Still, he is having persistent V's. Can you guess, anyone, please? So you assess the tracheal shadow. When you assess the tracheal shadow, here right main bronchus is not seen clearly, very narrowed right main bronchus. Left main bronchus also very narrowed opening over here. So there is something over here which may be the cause for wheezing. So you can see the CT scan, a cranial mass which causes the narrowing of the both main bronchus. I think that's all today. Any questions?
ക്വസ്റ്റ്യൻസ് ഉണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാവുന്നതാണ്, അല്ലെങ്കിൽ ചാറ്റ് ബോക്സിൽ ടൈപ്പ് ചെയ്യാവുന്നതാണ്.
Somebody can read chat box in ping. Any questions in the chat box? Abhilash?
സർ അഭിലാഷ് സാർ ഡ്രൈവിംഗിലാണ് ഇപ്പൊ. വേറെ
അല്ല സാർ, ഞാൻ ജസ്റ്റ് റീച്ച് ചെയ്തു. ഹലോ രാഹുൽ,
Okay.
ഞാൻ റീച്ച് ചെയ്തു. ക്വസ്റ്റ്യൻസ് എല്ലാം സാറിനെ കൺഗ്രാജുലേറ്റ് ചെയ്തുകൊണ്ടുള്ള ചാറ്റാണ്. എക്സലന്റ് സെഷൻ, വണ്ടർഫുൾ സെഷൻ എന്നാണ്. നമുക്കിന്ന് മാക്സിമം പാർട്ടിസിപ്പേഷനും ഉണ്ടായിരുന്നു. ആരും ക്വസ്റ്റ്യൻസ് ചോദിക്കുന്നില്ല. ആർക്കെങ്കിലും അൺമ്യൂട്ട് ചെയ്ത് ക്വസ്റ്റ്യൻ ചോദിക്കണം എന്നുണ്ടെങ്കിൽ ചോദിക്കാം കേട്ടോ. എല്ലാവരും സാറിനെ കൺഗ്രാജുലേറ്റ് ചെയ്തുകൊണ്ടിരിക്കുകയാണ്.
Thank you.
സാറിന് ചോദ്യം വരുമോ? നമുക്ക് ഒരു മിനിറ്റ് വെയിറ്റ് ചെയ്യാം. ആരും ചോദ്യം ചോദിക്കുന്നതായിട്ട് കാണുന്നില്ല.
Okay.
ഞാന് ഡ്രൈവിംഗ് ആയിരുന്നു, അപ്പൊ അതുകൊണ്ട് സെഷൻ ജസ്റ്റ് ലാസ്റ്റിലോട്ടാണ് സാറിനെ കേട്ടത്.
Okay. എന്നാ നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം അല്ലേ?
വൈൻഡപ്പ് ചെയ്യാം സാർ. നമ്മുടെ പാർട്ടിസിപ്പൻസിന്റെ ഫീഡ്ബാക്ക് വെച്ച് തീർച്ചയായിട്ടും ഇത് വളരെ വണ്ടർഫുൾ സെഷനാണ്. താങ്ക് യു വെരി മച്ച് സാർ. സാറിനെ ഏതായാലും അപ്രോച്ച് ചെയ്തപ്പോ തന്നെ സാറ് വളരെ പെട്ടെന്ന് തന്നെ സാർ അത് സമ്മതിക്കുകയും ഇത്രയും ഷോർട്ട് നോട്ടീസിൽ തന്നെ സാർ അത് എല്ലാം റെഡിയാക്കി. ക്ലാസ് ഏതായാലും വളരെ വണ്ടർഫുൾ ആയിരുന്നു. ഫീഡ്ബാക്ക് ഏതായാലും എനിക്ക് തോന്നുന്നു നമുക്ക് വളരെയധികം പാർട്ടിസിപ്പേഷൻ കിട്ടിയ ഒരു സെഷൻ കൂടിയാണ്. സാറിന് ഏതായാലും ഞങ്ങളുടെ KGMOA അക്കാഡമിക് സെല്ലിന്റെ പേരിലും KGMOയുടെ പേരിലും സാറിനെ ഞങ്ങളുടെ ഹൃദയത്തിൽ നിന്നുള്ള നന്ദി അറിയിച്ചുകൊള്ളുന്നു. താങ്ക് യു വെരി മച്ച് സാർ.
Thank you.
സാർ, ഈ ഒക്കൾട്ട് ന്യൂമോതെറാക്സ് അത് ചിലപ്പോ പലപ്പോഴും മിസ്സായി പോകുന്നുണ്ട്. അപ്പൊ അത് നമ്മളെ എങ്ങനെയാണ് സസ്പെക്ട് ചെയ്യാതെ കണ്ടുപിടിക്കുക?
ന്യൂമോതൊറാക്സ് സാധാരണ നമ്മൾ ബേസിക് ഇൻവെസ്റ്റിഗേഷൻ എക്സ്റേ ആണ് എടുക്കുക. നമുക്ക് ക്ലിനിക്കൽ കേസ് സിനാരിയോ ആയിട്ട് കോറിലേറ്റ് ചെയ്യണം. ഓൾറെഡി ഒരു പാരങ്കൈമ ഡാമേജ്ഡ് പാരങ്കൈമ ആണെങ്കിൽ ഈവൻ മിനിമൽ ന്യൂമോതൊറാക്സ് വിൽ ബി സിംറ്റമാറ്റിക്. സപ്പോസ് പേഷ്യന്റ് ഈസ് സിവിയർലി COPD patient or interstitial lung disease or any structural lung disease patient, even minimal pneumothorax will be symptomatic. In that case, you have to have a high index of suspicion and try to take a expiratory film to look for pneumothorax in that case. If that is not evident, then you have to go ahead with the CT scan to demonstrate pneumothorax. The confusion over here is when emphysematus bulla are there, you'll be confused whether it is bulla or pneumothorax. If you put a tube into the bulla, you will get a bronchopleural fistula, and it will create a lot of issues. So it is always better to do a CT scan in cases which where you are confused with the bullae, and if you are not able to make out pneumothorax, though clinically you suspect pneumothorax strongly.
സർ ഈ പോളിട്രോം
വൈഡനിങ് എങ്ങനെയാണ് നമ്മൾ കണ്ടുപിടിക്കുക?
എക്സ്റേ എടുക്കാൻ വേണ്ടി എഴുന്നേക്കുന്നില്ല, കിടന്നിട്ടുള്ള സുപ്പൈൻ എക്സ്റേ ആണ് എടുക്കുന്നത്. അപ്പോഴാണ് നമുക്ക് ഈ പ്രയാസം ഏറ്റവും ആയിട്ട് വരുന്നത്. ഈ ഡീപ് സൾക്കസ് സൈൻ അങ്ങനെയൊക്കെ ലങ്സ് ചിലപ്പോൾ നോർമൽ ആയിട്ട് തോന്നും, പക്ഷെ ഇങ്ങനെ ന്യൂമോതൊറാക്സ് നമുക്ക് മിസ്സായിട്ടുണ്ട്. അതാണ് സാറിന് ചോദിക്കുന്നത്.
ബെഡ് റിഡൻ പേഷ്യൻസിന് ഡീപ് സൾക്കസ് സൈൻ ഒരു നമുക്ക് ന്യൂമോതൊറാക്സ് സസ്പെക്ട് ചെയ്യാം. അൾട്രാസൗണ്ട് ആണ് അതിനേക്കാൾ കുറച്ചുകൂടെ നല്ലത്. അൾട്രാസൗണ്ടിൽ ന്യൂമോതൊറാക്സ് ഡോക്യുമെന്റ് ചെയ്യാൻ കുറച്ചുകൂടെ എളുപ്പമാണ്. എസ്പെഷ്യലി ട്രോമ പേഷ്യന്റിന് ED തന്നെ എമർജൻസി ഡിപ്പാർട്ട്മെന്റ് ഉണ്ടെങ്കിൽ അവർ തന്നെ അത് നോക്കി ന്യൂമോതൊറാക്സ് ഡോക്യുമെന്റ് ചെയ്യും. പിന്നെ പോളിട്രോമ പേഷ്യന്റ് സാധാരണ ഒരു റുട്ടീൻ CT സ്കാനിന് നമ്മൾ ചെയ്യാറുണ്ട്. അപ്പം അതിനകത്ത് അത് എന്തായാലും കിട്ടും. ഇനിയിപ്പോ ഇൻ കേസ് ക്ലിനിക്കലി എയർ എൻട്രി കുറവാണ്, മൾട്ടിപ്പിൾ റിഫ്രാക്ചർ ഉണ്ടെങ്കിൽ ഒരു പ്രൊഫലാറ്റിക് ആയിട്ട് ഒരു ഇന്റർകോസൽ ട്യൂബ് ഡ്രെയിനേജ് ഇടുന്നതിന് വിരോധമില്ല. സപ്പോസ് എയർ എൻട്രി ഡിക്രീസ്, ഇറ്റ് ഈസ് ഹൈപ്പർ റെസൊണന്റ്, ദോ എക്സ്റേ is not confirmatory of any pneumothorax, there is no harm in putting ICD if patient is really sick and in respiratory distress. That's what we usually do for trauma patients.
മീഡിയസ്റ്റൈനൽ വൈഡനിങ് എങ്ങനെയാണ് നമ്മൾ കണ്ടുപിടിക്കുക?
മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് നമ്മൾ ടോപ്പ് ടു ബോട്ടം മീഡിയാസ്റ്റൈനത്തിന്റെ ബോർഡേഴ്സ് നോക്കാം. റൈറ്റ് പാരാട്രക്കൽ ഏരിയ സാധാരണ ഒരു തിൻ സ്ട്രിപ്പ് ഓഫ് സോഫ്റ്റ് ടിഷ്യൂ മാത്രമേ ഉണ്ടാവുള്ളൂ. ഇറ്റ് ഈസ് ലെസ് ദാൻ 3 millimeter. ഒന്നാമത് എക്സ്റേ നല്ലൊരു സ്റ്റാൻഡേർഡ് PUV ആയിരിക്കണം. ഈ അപ്പാരന്റ് മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് സുപ്പൈൻ എക്സ്റേയിലും APVയിലും ഒക്കെ സാധാരണയായിട്ട് കാണാറുണ്ട്. അപ്പോൾ ഒരു എമർജൻസി എക്സ്റേ വെച്ചിട്ട് മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് ഡോക്യുമെന്റ് ചെയ്യരുത്. If you are confused, do a PAV, standard PAV. അപ്പം upper part of the mediastinum on the right side of the paratracheal area, thin strip of soft tissue മാത്രമേ ഉണ്ടാവുള്ളൂ, 2 to 3 millimeter. അതിനേക്കാൾ കൂടുതൽ ഉണ്ടെങ്കിൽ that means there is definitely mediastinal widening in the right paratracheal area. അപ്പോൾ അത് എന്തായാലും CT ചെയ്ത് നോക്കുക. സാധാരണ അത് ലിംഫ് നോഡോ ആവാം, ചിലപ്പം ഈ സുപ്പീരിയർ വീന കവൽ ഡയലറ്റേഷൻ കാരണം ചിലപ്പോൾ ഉണ്ടാവാറുണ്ട്. ചില അബ്നോർമൽ ആർട്ടറീസ് ലൈക്ക് ഇപ്പോൾ കോമറലി ഡൈവർട്ടിക്കുലം, അല്ലെങ്കിൽ റൈറ്റ് സൈഡ് ഡയോട്ടിക് ആർച്ച്, അല്ലെങ്കിൽ ഈ ലെഫ്റ്റ് സൈഡത്തെ സബ് ക്ലേവിയൻ ആർട്ടറി റൈറ്റിൽ നിന്ന് ഒറിജിൻ ചെയ്ത് കർവ് ചെയ്തൊക്കെ പോകുന്ന വാസ്കുലർ അനോമലീസ്, ഇതെല്ലാം മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് ഉണ്ടാക്കാറുണ്ട്. പക്ഷേ എന്തായാലും മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് ഉണ്ടെങ്കിൽ നമുക്ക് ഇൻവെസ്റ്റിഗേറ്റ് ചെയ്തേ പറ്റൂ. ഒരു കോൺട്രാസ്റ്റ് CT ചെയ്യണം, ലിംഫ് നോഡാണ് ഇൻവെസ്റ്റിഗേറ്റ് ചെയ്യണം. വാസ്കുലർ അബ്നോർമാലിറ്റി അങ്ങനെ എന്തെങ്കിലുമൊക്കെയാണ് ഇപ്പോൾ ഫാറ്റ് ടിഷ്യൂ ചിലപ്പോൾ ചിലർക്ക് കാണാം, എങ്കിലും ദർ ഇസ് നോ ഹാം ഇൻ ഇൻവെസ്റ്റിഗേറ്റിംഗ് ഫർദർ. അപ്പം റൈറ്റ് പാരാട്രക്കിൽ ഏരിയ ഇഫ് ദ സ്ട്രൈപ്പ് ഈസ് മോർ ദാൻ 3 millimeter, ഇറ്റ് ഇൻഡിക്കേറ്റ് മീഡിയാസ്റ്റൈനൽ വൈഡനിങ്. ലെഫ്റ്റ് സൈഡിലാണെങ്കിൽ സബ്ക്ലേവിയൻ ആർട്ടറി അയോട്ടിക് ആർച്ചായി ബ്ലെൻഡ് ചെയ്യുന്നത് അവിടെയും തിൻ സ്ട്രൈപ്പ് തന്നെ ഉണ്ടാവുള്ളൂ, അവിടെ ബൾജിനെ നോക്കണം. പിന്നെ നമുക്ക് വേണമെങ്കിൽ മീഡിയാസിന്റെ ഡയമീറ്റർ മെഷർ ചെയ്ത് നോക്കാം. മീഡിയാസിന്റെ ഡയമീറ്റർ ഔട്ടർ ബൾജിങ് ഉണ്ട് ഒരു 5 centimeter കൂടുതൽ ഉണ്ടെങ്കിൽ സാധാരണയായിട്ട് മീഡിയാസ്റ്റൈനൽ വൈഡനിങ് സസ്പെക്ട് ചെയ്യാം. പിന്നെ അതിന്റെ ഷേപ്പ് കണ്ടറിയാം. നോർമൽ ഷേപ്പിനെ വിട്ടിട്ട് ഒരു ബൾജിങ് അവിടെ ഇവിടെയൊക്കെ ഉണ്ടാവും, എസ്പെഷ്യലി 4R നോഡ്, അതായത് ലോവർ പാരാട്രക്കിൽ നോഡൊക്കെ ആണെങ്കിൽ ഒരു ബൾജിങ് ഔട്ട് ശരിക്കും കാണാം. റൈറ്റ് മെയിൻ ബ്രോങ്കസിന്റെയും ട്രക്കേഡിയ ജംഗ്ഷനിൽ ഒരു ബൾജ് കാണാം. താഴേക്ക് വരുമ്പം റൈറ്റ് എട്രിയത്തിനെ ഓവർലാപ്പ് ചെയ്തിട്ടൊരു ബൾജ് ഔട്ട് കാണാം. അതുപോലെ ലെഫ്റ്റ് സൈഡിൽ റിട്രോ കാർഡിയാക്കിൽ കാണാം. അപ്പം മീഡിയാസ്റ്റൈനം ശരിക്കും ടോപ്പ് ടു ബോട്ടം നോക്കുക, ഡീറ്റെയിൽ ആയിട്ട് തന്നെ നോക്കണം. എന്തെങ്കിലും ഒരു സസ്പിഷൻ ഉണ്ടെങ്കിൽ ഇറ്റ്സ് ഓൾവേസ് better to do CT scan because mediastinum is an hidden area. നമുക്കറിയില്ല, ചിലപ്പോൾ ലീഷൻ എക്സ്റേ കാണും ചെറുതായിരിക്കും, CT ചെയ്യുമ്പോഴും വിൽ ബി സർപ്രൈസ് ടു എ ലാർജ് മാസ് ലീഷൻ ഓക്യുപ്പൈങ് വിച്ച് ഇസ് നോട്ട് ഏബിൾ ടു സീ ഇൻ ദ എക്സ്റേ. സോ mediastinal area you should evaluate further if you have any suspicion.
സർ പൾമനറി എംബോളിസത്തിന്റെ എക്സ്റേ ഫൈൻഡിങ്സ് ഒന്ന് പറയാമോ സർ?
പൾമണറി എംബോളിസം ഞാൻ ഒരു എക്സ്റേ ഇതിൽ വെച്ചായിരുന്നു, പിന്നെ ഞാൻ ക്യാൻസൽ ചെയ്താണ്. സാധാരണ നമുക്ക് കിട്ടാം പൾമണറി ഒലിഗീമിയ, അതായത് ഫോക്കൽ പൾമണറി വെസൽസ് കാണില്ല. അപ്പൊ നമ്മൾ റൈറ്റ് ലെഫ്റ്റ് കമ്പയർ ചെയ്യുമ്പോൾ റൈറ്റ് സൈഡിന്റെ അത്ര വാസ്കുലാരിറ്റി ലെഫ്റ്റിലില്ല. ദാറ്റ് ഇസ് കോൾഡ് ഫോക്കൽ പൾമണറി ഒലിഗീമിയ. ദാറ്റ് ഇസ് വെരി ഇമ്പോർട്ടൻറ്റ് സൈൻ. എനിക്ക് തോന്നുന്നു റേഡിയോളജിക്കൽ സൈനേക്കാൾ ആദ്യം തന്നെ നമ്മൾ പേഷ്യന്റ് വെദർ പേഷ്യന്റ് ഇസ് റിസ്കി ഫോർ പൾമണറി എംബോളിസം അതാണ് ആദ്യം നോക്കേണ്ടത്. അത് നമുക്ക് പല ഗ്രേഡിങ്ങും സ്കോറിംഗ് ഒക്കെ ഉണ്ട്. വെൽ സ്കോറോ അല്ലെങ്കിൽ നോക്കുക, പേഷ്യന്റ് ബെഡ് റിഡൻ ആണ്, റീസെന്റ് സർജറി ഉണ്ട്, പ്രീവിയസ് DVT ഉണ്ട്, വേരിക്കോസ് വെയിൻ ഉണ്ട്, അങ്ങനെ ഒരു ഫാമിലി ഹിസ്റ്ററി ഓഫ് DVT അല്ലെങ്കിൽ പൾമണറി എംബോളിസം. അപ്പൊ അങ്ങനെയുള്ള ഒരു ബാക്ക്ഗ്രൗണ്ടിലുള്ള പേഷ്യന്റ് ആണെങ്കിൽ ദോസ് പേഷ്യൻസ് ആർ ലൈക്ലി ടു ഹാവ് പൾമണറി എംബോളിസം. അതിന്റെ കൂടെ നമ്മൾ ECG എവിഡൻസ്, ടക്കിക്കാർഡിയ ഉണ്ട്, പേഷ്യന്റ് സാച്ചുറേഷൻ ഫോൾ ഉണ്ട്, ഡൈമർ ഹൈ ആണ്. എക്സ്റേയില് ഈ പറഞ്ഞ മാതിരി ഫോക്കൽ ഒലിഗീമിയ വെസ്റ്റർമാർക്ക് സൈൻ എന്ന് പറയും. പിന്നെ ചിലപ്പോൾ പെരിഫറലി നെക്രോട്ടിക് ആയിട്ട് ഹാംപ്ടൺ ഹമ്പ് കാണാം. പിന്നെ പൾമണറി റൈറ്റ് പൾമണറി ആയിട്ട് ഡൈലേറ്റ് ചെയ്തിട്ട് കാണാം, പല്ലാ സൈൻ എന്ന് പറയും. ബാക്കിയുള്ള സൈനുകളൊക്കെ നമുക്ക് കോൺട്രാസ്റ്റ് എൻഹാൻസ് CT അല്ലെങ്കിൽ CT പൾമണറി ആൻജിയോഗ്രാഫിയിലാണ് കിട്ടുക. അതിൽ നമുക്ക് ചിലപ്പം ഒരുപാട് സയൻസ് കിട്ടും. ആ എംബോളിസം ഉള്ളതിന്റെ സയൻസുകൾ ഒത്തിരി ഉണ്ട്. പോളോമിന്റ് സൈൻ, പോളോമിന്റ് പോലെ റൗണ്ടിൽ കാണും. അപ്പൊ അങ്ങനെ കുറെ സൈനുകൾ വേറെയുണ്ട്. പക്ഷെ എക്സ്റേ സംബന്ധിച്ചിടത്തോളം നമുക്ക് ഫോക്കൽ പൾമണറി ഒലിഗീമിയ ഓർ വെസ്റ്റർമാർക്ക് സൈൻ, ഹാംപ്ടൺ ഹമ്പ്, എൻലാർജ്ഡ് റൈറ്റ് പൾമണറി ആർട്ടറി, പല്ലാ സൈൻ, ഇതൊക്കെയാണ് സാധാരണ കാണാറ്. പക്ഷെ എക്സ്റേ മാത്രം വെച്ച് ഡയഗ്നോസ് ചെയ്യുന്നതിനേക്കാളും പേഷ്യന്റ് ബാക്ക്ഗ്രൗണ്ടും ECG ഫൈൻഡിങ്ങും ടക്കിക്കാർഡിയ, ഡൈമർ എല്ലാം കൂടി കോറിലേറ്റ് ചെയ്ത് കഴിഞ്ഞാൽ യൂഷ്വലി നമുക്ക് കുറെ കേസിൽ ഡയഗ്നോസ് ചെയ്യാം. എങ്കിലും എക്സ്റേ വിൽ ബി നോർമൽ ഇൻ മോസ്റ്റ് ഓഫ് ദ പൾമണറി എംബോളിസം കേസ്. അപ്പോൾ സ്ട്രോങ് സസ്പിഷൻ ഉണ്ടെങ്കിൽ ഗോ ഹെഡ് വിത്ത് CTPA എന്നായിരിക്കും നല്ലത്.
സർ, ഈ AI ഉപയോഗിച്ചിട്ട് ഇത് ഡയഗ്നോസ് ചെയ്ത ക്യുറേ AIയുടെ റിപ്പോർട്ടൊക്കെ ഇടയ്ക്ക് കാണുന്നുണ്ട്. അപ്പൊ അതിന്റെ ഒരു അക്യുറസി അല്ലെങ്കിൽ നമുക്ക്
അതിന്റെ അക്യുറസി വെച്ചാല് എക്സ്റേക്ക് ഏറ്റവും ആദ്യം വേണ്ടത് ഒരു ക്ലിനിക്കൽ ബാക്ക്ഗ്രൗണ്ട് നമുക്ക് ഇല്ലാണ്ട് എക്സ്റേ മാത്രം കണ്ടു കഴിഞ്ഞാൽ ഒരുപാട് എന്താ പറയാ റോങ് ഡയഗ്നോസിസ് വരും. AI മാത്രം ഇപ്പൊ നമ്മൾ ഒരു എക്സ്റേ ഇട്ട് കഴിഞ്ഞാൽ ഒരുപാട് കാര്യങ്ങൾ വരും, നമ്മളെ ട്രാക്ക് മാറ്റി ചിന്തിക്കും. ഇപ്പോഴത്തെ ഒരു പ്രധാന പ്രശ്നം AI വരുമ്പോൾ പേഷ്യന്റിന്റെ ബാക്ക്ഗ്രൗണ്ട് മറക്കുക എന്നുള്ളതാണ്. നമ്മൾ ഒരു എക്സ്റേ മാത്രമേ AIക്ക് കൊടുക്കണുള്ളൂ, ഇൻപുട്ട് വേറെ ഒന്നും കൊടുക്കുന്നില്ല. അപ്പൊ AI ഒരുപാട് ഡിഫറൻഷ്യൽ ഡയഗ്നോസിസ് തരും. നമ്മൾ നമ്മുടെ ക്ലിനിക്കൽ ഹിസ്റ്ററി വെച്ചിട്ട് കുറെ ഡിഫറൻഷ്യൽ ഡയഗ്നോസിസ് റൂൾ ഔട്ട് ചെയ്തിട്ടുണ്ടാവും. ഈ ഒരു സംഭവം AI നടക്കില്ല എന്നുള്ളതാണ് പ്രശ്നം. അതേസമയം നല്ല AI നമുക്ക് നമ്മൾ ചിന്തിക്കാത്ത കാര്യങ്ങൾ ആലോചിക്കാനായിട്ട് ഹെൽപ്പ് ചെയ്യും. അത് മാത്രമേ അതിന്റെ അഡ്വാൻറ്റേജ് ഉള്ളൂ. യൂഷ്വലി AIയുടെ പ്രശ്നങ്ങൾ ഇതൊക്കെയാണ്. നമ്മൾ ചിന്തിക്കാത്ത കുറെ ഡയഗ്നോസിസ് വരും, പക്ഷെ അത് ശരിയാവണമെന്നില്ല. ഇറ്റ്സ് ഓൾവേസ് ബെറ്റർ ടു കോറിലേറ്റ് വിത്ത് അവർ ക്ലിനിക്കൽ ഹിസ്റ്ററി ആൻഡ് പേഷ്യന്റ് ഡീറ്റെയിൽസ്, എക്സാമിനേഷൻ, ഫൈൻഡിങ് ആൻഡ്.
ഒരു ചോദ്യം മാത്രം. എനി അതർ ഇൻഡിക്കേഷൻ ഫോർ എക്സ്പിറേറ്ററി ഫിലിം അതർ ദാൻ സ്മോൾ ന്യൂമോതൊറാക്സ്?
എക്സ്പിറേറ്ററി ഫിലിം നമ്മൾ എയർ ട്രാപ്പിങ്ങിന് ഡോക്യുമെന്റ് ചെയ്യാനാണ് സാധാരണ ഉപയോഗിക്കുക. എയർ ട്രാപ്പിംഗ് ഇൻ ദ ലങ്, ലൈക്ക് ഇപ്പം ഹൈപ്പർ സെൻസിറ്റിവിറ്റി ന്യൂമോണിയ, അല്ലെങ്കിൽ ഇപ്പം ഒരു ഒബ്സ്ട്രക്റ്റീവ് എയർ ഡിസീസ്, COPD, എംഫിസിമ, ഇതിലെല്ലാം ശ്വാസം പുറത്തേക്ക് വിട്ടാലും ആ ലങ് അങ്ങ് കൊളാപ്സ് ചെയ്യില്ല. സോ എയർ ട്രാപ്പിംഗ് ഉള്ള ഡിസീസസിന്റെ ഒരു ഡയഗ്നോസിസ് സാധാരണ CTയിലാണ് നമ്മൾ ചെയ്യുക. പക്ഷെ പണ്ട് കാലത്ത് നമ്മൾ എക്സ്റേയിലും ചെയ്യാറുണ്ട്. ബ്രീത്ത് ഔട്ട് ചെയ്യുമ്പോൾ ലങ് ചുരുങ്ങില്ല, അതാണ് എയർ ട്രാപ്പിംഗ് എന്ന് ഉദ്ദേശിക്കുന്നത്. അപ്പം ഒബ്സ്ട്രക്ഷൻ ഉണ്ടെങ്കിൽ, സ്മോൾ എയർവേയിൽ ഒബ്സ്ട്രക്ഷൻ ഉണ്ടെങ്കിൽ എയർ അങ്ങ് പോകത്തില്ല ബ്രീത്ത് ഔട്ട് ചെയ്താലും. അപ്പം എയർ ട്രാപ്പിംഗ് ഈസ് എ സൈൻ ഓഫ് ഹൈപ്പർ സെൻസിറ്റീവ് ന്യൂമോണൈറ്റിസ്, സ്മോൾ എയർവേ ഒബ്സ്ട്രക്ഷൻ. ന്യൂമോതൊറാക്സ് നമുക്ക് ചെറിയ ന്യൂമോതൊറാക്സ് കുറച്ചും കൂടെ വലുതായി കാണാൻ വേണ്ടിയിട്ടാണ് എക്സ്പിറേറ്ററി ഫിലിം ചെയ്യുന്നത്.
Okay, sir. Once more, we thank you very much, sir, for addressing us and clearing our doubts. Thank you, sir.
Okay, thank you.
Okay, sir. Good night, sir.
Okay, good night to all.
Good night, sir. Thank you.